What a build-up. I've got to try not to be boring now. Morning, everyone. My name's Kerry Ord. I'm the Exec Director for Adult Social Care and Public Health at Walsall Council. Um, so today's title, I think, for the seminar was Commissioning ICBs. And worryingly, this is where Sam cringes. But I'm not going to talk that much about commissioning because actually, I think if we'd started our journey in Walsall through a commissioning lens, we wouldn't have got to where we are today. But it absolutely does weave in the approach to commissioning that we took in Walsall. So I'm going to tell you the story of our place-based partnership and our integrated care arrangements. And this story started for me back in 2016. So in 2016, I joined Walsall Council, and we were really, really lucky in Walsall in that there was already a forum. It's called the Healthy Walsall Partnership Board. And I was absolutely astounded to see all of the senior leaders from across the Walsall patch. So chief executive of the hospital, chief executive of the council, and various other leaders from across the sector, all sitting around a table, all speaking nicely to each other with a shared ambition. For some of those that work in some of the more troubled economies up and down the country, which I've worked in previously, you'll know that that's an unusual thing. And they were very brave because they did two things. The first thing that they did is they recognised that actually they weren't getting anywhere. So although they were sitting around the table on a really regular basis, having great conversations and generally being really nice to each other, they weren't actually delivering programs of activity that were helping them to achieve those ambitions. It became an opportunity in that a number of key posts from across the system were being appointed at that time, and mine was one of them. So I came with a very, very clear brief that I was to integrate. That was my brief when I was recruited, and the deputy director for commissioning, it was CCG at that point, of course. The deputy director of commissioning was being appointed at the same time, and there was also some new people in post in the mental health trust and the local acute trust. So what the Healthy Walsall Partnership Board did was that it invested in a systems leadership approach. So it got all of the, and it's a horrible term, but I'll use it anyway, because that's what the term that was used at the time, all the seconds in the command. So all of the people that were reporting to the most senior people within those organisations, it got 5 or 6 second in commands together on a systems leadership training. We came together on a weekly basis, and our aim was to work out how our organisations could work better together. And oh no, I can see on my screen. Oh, there we go. Thank you very much, whoever pressed the button. What you can see on the screen on the right there is we very quickly moved to what are the opportunities in our patch for integration? Where are the places that actually we can more successfully work together and deliver better outcomes? So you'll all, I'm sure, have various iterations of this particular model in your areas. Typical target model. What we came up with is a target model that offered us, we felt, 4 opportunities for integration. Those 4 opportunities for integration were around our communities, so making our communities stronger, more resilient, so that they keep well and independent for longer. The next was around how we work together in place. So how we work together in communities where people were experiencing either health or care needs or other challenges. So in that space is our multidisciplinary teams, our care home enhanced services, and other services like that. So services that keep people well when they do have health and care challenges. The third tier was kind of our specialist community services, so the services that are at the pointy end, if you like, of our health and care system. So it's those services that either keep people out of hospital or get people out of hospital when unfortunately they end up there. And then the fourth opportunity was around how we coordinate all of that. So that system navigation, how do we make it seamless for individuals when they approach one part of our system? So they were the four opportunities that we identified. And we did some work then to look at what the programs of activity could be in order to move forward on those areas. We very quickly realised, sorry, this one's a long slide, the previous one.
Apologies.
It's all right, don't worry. We very quickly realised that we couldn't do it as just the 5 or 6 of us that were second in commands, and we realised that actually we needed to engage with the whole system in order to deliver on some of these aims. So we very quickly expanded our partnership, and we had all parts of health, so primary, secondary, community, mental health, senior colleagues, the council, so children's, adults, public health, and both commissioners and operations. Our local housing group, and our housing group represented the Walsall Housing Alliance, and crucially our voluntary and community sector. The second brave decision that then that bunch of leaders had was to commission at the time it was one of the big ones. Which one was it? It was KPMG. KPMG to work alongside us to give us some capacity and some capability around bringing that programme together. And so we created a business case, and they supported us in putting some of the key governance in place. And from there, Walsall Together was born. Walsall Together is our place-based partnership, and as I say, it includes all those partners that I've just mentioned, and it included some programme of activity to move us to where we are today. We're now moving into this. This took us 18 months, so we're now moving into kind of 2018-19 when Walsall Together was born. So I'm just gonna move on now to one of the things that we developed within the business case. Next slide, please. Thank you. So what we realised really early on is that integration meant different things to different people across the partnership, and actually integration wasn't our aim. Our aim was to deliver good service, good outcomes to the people of Walsall, and where it made sense to do that in an integrated way, to do it in an integrated way. And we realised that actually integration didn't need to be the same for all of those different opportunities either. So what you can see here is, I call it my spectrum of purple, actually, rather than my spectrum of integrated delivery, but the spectrum of purple. So what we realised is, for some types of integration, it's okay to just have separate teams, but just increase collaboration. How are you going to talk to each other? How are you going to work together on a daily basis? So you see that down in the palest purple on the left-hand side there. For some, it needs more robust integration arrangements, so single function, co-located teams. So you can see that in the darker purple as you move around. And then the most structural type of integration, so the most formal integration, single function, full structural integration, where it's normally in one organisation delivering that service. When we were working then through those opportunities and the business cases for those opportunities, we were able to kind of plot our ambition. So where do we think that what suited that particular type of delivery? So, for example, intermediate care, we recognise that actually the functions are pretty evenly spread. So we needed all of the components of our partnership integrated to deliver a single service. So we kind of went around the second or third in deepest purple on that spectrum, so single function, co-located with a single manager. Whereas for other services, for example, our MDTs, actually we didn't feel that they needed a single manager or to be hosted by a single organisation. So we went with separate teams, some integrated functions, shared documentation for multidisciplinary teams. Move on, please, then. So I'll just give you some examples, just to make it real, of how we then went on to deliver these services. I have to say, it's really bizarre presenting this presentation by myself. I've normally got my my colleagues sat next to me. So my voluntary sector lead, my housing group lead, normally are sitting right next to me. So if I mess this up, they're going to crucify me because they do some of these bits. So yeah, I'm going to talk about intermediate care because that was our flagship service. So our intermediate care, when we picked this up, was 11 disparate services. Some of you will recognise this in your own economies, but we would have a reablement service hosted by the council. We'd have a discharge hub that had elements of health staff in it, elements of social care staff in it. We had then bed-based pathways that were commissioned by the Healthcare Trust, bed-based pathways that was commissioned by the local authority. But all in all, we had 11 disparate bits of the puzzle and 11 funding streams for those different bits of the puzzle. And we were spending an awful lot of money on that. So we worked together to look at, okay, how would we do this if we had a blank sheet of paper? And this is where that partnership came into its own, because we were just dead honest. We were dead honest, we were dead open. Everyone stuck their budgets on the table. It was, right, this is the total envelope that we've got for this. Some of our commissioners were cringing because they wanted to just go and sit in a dark room and create a service specification and give a budget that probably wouldn't be enough to the Healthcare Trust to deliver this, but that just wouldn't have achieved the outcomes that we wanted to achieve. So we were dead open, dead honest, started with a blank sheet of paper, put the budget on the table, and we designed a service that we felt would deliver the outcomes that we wanted to deliver. So we ended up with a true discharge to assess model. This is before the discharge guidance that came out much later. We were slightly ahead of the curve, although I would argue that some places have been doing this for a very long time. So the discharge guidance was very late to catch up. We were fully integrated. So we decided that we needed a host organisation for this. We had all of the disciplines that you would expect in a discharge hub. We had our nurses, OTs, physios, social workers, trusted assessors, reablement staff, and voluntary sector organisation, and housing, although it wasn't integrated in the team, housing work along had links into the team too. Move on to what did it do? So medically fit for discharge, I'm sure language that most of you will recognise, and I'm sure it's the bane of some of your lives on a regular basis. And it was ours at the point that we started this. So at the point that we started this, we had medically fit for discharge numbers of 140, 150 people on that list on a regular basis. We run now regularly sub 50. When it's good, we're sub 30. But we haven't been over 50 now for a little while. So the numbers on the list have reduced significantly. Moving on. More importantly as well, the length of stay. Once people hit that list, so once people are medically fit for discharge, the length of stay is reduced dramatically. So at the point that we started this transformation, we were averaging between 10 and 15 days once somebody was medically fit for discharge for them to leave the hospital with whatever their onward journey was. We now average between 0 and 2 days. Most people get out on the same day. It can take up to 3 or 4 days if it's a bit more complex. But we're averaging between 0 and 2 days. Moving on. And you can see there that the vast majority of the people that leave the hospital do go into home-based pathways, they go into pathway 1. That was a really important indicator for us. So yeah, you can see just under 84%, and it's actually slightly higher than that now. And this performance, although that's quite old performance data now, and we've used these slides for the last 12-18 months. That performance has been maintained. So all the way through the winter, this winter, through the pandemic, we've maintained really good performance. So where people have felt the pinch of long queues of ambulances outside of hospital, touch wood, oh God. we haven't experienced that, and flow through our hospital is really good. It was also a godsend to us through the pandemic. So because we had those structures in place where we met as a senior management group on a really regular basis, we were able to mobilise really quickly to step up some of the support pathways to support the hospital to maintain that flow. One of the things that we did was we had a stroke ward in our hospital, that there was always plans to move this stroke ward out of the hospital into the community, and we'd been plugging at it for about 18 months and not getting anywhere. We needed those beds during the pandemic, and so one Friday the senior management group met. We said, you know what, we just need to do it. And so the housing group, we had a building that we weren't occupying, and we were using it as office space. Of course, during the pandemic, nobody was in the office space because we were all sat at home. It was still kitted out as a bedded unit, so it still had all of the bays that were there. Didn't have any of the beds, didn't have some of the walls or doors that we needed. So the housing group swooped in, turned it back into a bed-based unit literally over the weekend. The hospital swooped in and kitted it out with equipment, beds, all of the stuff that you would expect. The equipment stores that do all of our community equipment, etc. They swooped in and kitted it out with all of the peripherals that we needed, and we teamed together, and we got a staff team of housekeepers, catering staff, etc. And we literally opened it up within about 4 or 5 days, and within 2 weeks, the whole ward moved into that unit. It's still open today. I'll say that hesitantly because actually it had a gas leak, and so actually it had to close, but it's back open again, I think, on Monday. But yes, that's the sort of thing that we were able to do just by being that single integrated team. Moving on then, please. I'm not going to go through this slide, but what we're trying to do now is just build on that that program of activity, because although it's been great for a number of years now, it's always got those teething problems, and there's always little snags that you've got to address, but we do it together still. So it's still a hosted service. It's still that whole group of senior managers that come together to problem solve when we do have problems. Moving on then, please. So so that obviously is one of the flagships service of Walsall Together, and it was one of the services that used all of the partners, and it's at that the pointy end, if you like, of the system. But we deliver a whole range of programs as a partnership. So Kindness Rocks, that was a program that was led on by our housing group, but it involved all of the partners pulling together to tackle loneliness and isolation, which was highlighted as one of our main issues in terms of demand for adult social care, but also people rocking up at GP surgeries and acute hospitals. So we created this project called Kindness Rocks, where over 1,000 people took part in painting rocks and then planting them in various parts of the borough. So you go from one extreme to the other, with really acute intermediate care service, right the way through to a really community-based, community-led project that really helped in reducing social isolation. So yeah, it reached out over 93,000 people within the borough. It's featured on a local radio show, and it really opened the door to signposting to local support services for people that were clearly struggling with loneliness and social isolation. Moving on, please. Work for Health is another one of our initiatives. So again, the power that we were all big employers within the borough. We recognised that we were all big employers within the borough, and actually there's a lot of unemployed people that just needed a bit of support to get into employment. So one of the things that one of the initiatives that we developed was getting local unemployed people, predominantly in Walsall housing groups, tenant properties, but we worked with the college and the Department of Work and Pensions to identify individuals and then match them to roles within a local acute hospital. You can see there from the data, 147 people secured employment through that route. It wasn't just identifying the people and matching them to jobs. We supported them with guaranteed interviews, interview techniques. Some people hadn't had a job ever, and actually just getting out of bed and getting up and washing and dressed in the morning wasn't a regular routine that they were used to. So we did a lot of support for individuals as well, to get them to the stage that they were ready for interview and moving into employment. So you can see some of the data there. I'm not going to go through it, but we estimate that the social value that generated was about £2.1 million. Moving on. And then managing long-term conditions is a real key focus for us. So Walsall, for those that don't know it, is quite has some real pockets of social deprivation and health inequality. So diabetes is one of the major factors within our borough. So we, again, in partnership, created the Diabetes Champions programme, community outreach. We've been conducting those visits since October 23. 562 people have engaged with that so far, and we're finding that that education support, just that one-to-one, sometimes just using the community outreach that we've got in those different cultural languages that we have in the borough. We have a very diverse borough. Has really helped people to understand their diabetes and to manage it better. So we're seeing reductions in people that are needing more acute support in relation to diabetes, and you can see there that we've had a couple of people that have actually just reversed their type 2 diabetes completely. It's a really good success. And then this is one of our kind of infrastructure-y bits. So one of the things that we recognised that was it is really, really difficult to left shift, if you like, so to move money from really acute services into community and voluntary sector organisations and low level initiatives that have really high impact, but it's difficult to demonstrate. So we conducted a massive exercise to create a wellbeing outcome framework, so we could commission services and demonstrate their impact using a much broader range of indicators than just the usual indicators of widgets or activity or the standard public health or health outcome frameworks or adult social care outcome frameworks. So we've created this wellbeing outcome framework. If you can move forward, it's got a bit more detail on thank you very much. So it's a co-produced framework. We looked at what was meaningful for individuals, what were the evidence-based interventions that would also make a difference to the outcomes for individuals. It was 25 stakeholders working over 10 months to create this framework. We consulted with residents, but also with a wide range of professionals across the system. We did a desktop review of wellbeing and prevention documentation and outcome frameworks from across the world. My poor lead officer on this, I think she had very, very tired eyes at the end of it. I can't remember exactly how many research document she said she read, but it was phenomenal, and critiqued all of those research documents to get the absolute best evidence and best learning from across the world. Moving on, please. Oh no, sorry, I thought there was a slide that told you the outcomes of that, but the outcomes of the wellbeing framework is that we are now embedding that wellbeing outcomes framework in all of our commissioning across the borough. So it's now embedded within our adult social care outcomes framework, and we commission against that outcomes framework. It's embedded within public health, it's embedded within the ICB, so that when we're making decisions about commissions for the future, we're able to use that outcomes framework to more broadly commission services. Okay, moving on. So the next steps for Walsall Together, we're just now looking at our model and governance, and I can't underestimate the governance actually. Over the 6-7 years that we've been working on this, people have changed. I think I'm the only existing member of the original Walsall Together team now in Walsall, but those relationships are as strong as ever, and the reason that those relationships are as strong as they ever were, in my view, is that we worked really hard at getting proportionate but really good governance in place. So we have a Walsall Together board now that meet on a regular basis. It's independently chaired, and it's really rigorously governed. It is hosted by our Healthcare Trust. It is a subcommittee of the Healthcare Trust governance. We have an alliance agreement where all partners sign up to that, and that dictates how we work. It doesn't dictate the what, it just dictates the how we work. We then have a Section 75 agreement between the two main partners, Walsall Healthcare Trust and Walsall Council. That's a framework agreement, so it dictates again how we work together. And as we develop develop initiatives, we put schedules in that Section 75 agreement to tightly govern what we do. So that governance has helped us stick together as people have moved in and out of our system over that time. So that model and that governance is acting now as a blueprint for other places in the Black Country, and we're sharing it far and wide wherever we can. Part of the National Advisory Group in supporting the development of place-based partnerships, and we're influencing policy. So we're a front-runner side for the intermediate care and the major conditions strategy and the Health and Housing Forum. So finally, key messages, and I think I've gone over time, so I've not been having too many squinty looks, so I don't think I'm going to get into trouble. But key messages: this has definitely been a story of evolution, not revolution. So if anyone's looking for a quick fix, this is not it. It's start small, grow, but recognise that it will grow over time, as if you've got the good governance in place in the first instance. Put out the burning platforms. Intermediate care was our flagship service, because actually our Healthcare Trust could not move on and could not engage in more meaningful conversations until they sorted out their medically fit for discharge. And so that was our first priority. It was everybody's priority, including the voluntary sector and housing group, just because it was, we all recognised that if we didn't put out that burning platform, the Healthcare Trust would just not be able to engage with us on anything else. And so we put out that burning platform so that they could engage with us more meaningful on all the rest of the stuff. Find the win-wins by being open and transparent with the money, with the performance, with just transparency, basically talking about what our barriers are. We're able then to find the win-wins and move quickly on the win-wins, so that you've got that success and you can build on that success. I've already mentioned it, relationships are important. I have a weekly check-in with my exec still now, so all of the 5-6 execs, we meet. In fact, it's my next meeting. We meet on a weekly basis, and as I say, it's a equal relationship, but don't forget the governance. It's really important that we've got that governance in place to keep us safe, but also to be the consistent thing when people come in and out. Absolute importance is parity amongst the partners. So we call ourselves the execs, but there's in our execs are people that are paid an awful lot of money as the deputy chief executive of the local acute trust, sitting right next to our local voluntary sector partner, who is the spokesperson for the voluntary sector in our patch, who definitely does not get paid as much as our deputy chief executive of our healthcare trust. But there's absolute parity. As I say, ordinarily she'd be sat right here next to me and she'd have done half of those slides, which is why I probably made such a mess of them and took so long. And then finally, be brave and not precious. So if I'd have gone in there as a commissioner and said, this is my patch, you need to do this, it just absolutely would not have happened. If any one of us had pulled rank, thought about our organisation first, it wouldn't have worked. So yeah, be brave, not precious. And I think that's me. Thank you very much.